Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
In this video, we are covering endocrine pharmacology. We are covering a wide variety of drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. First, we will discuss oral hypoglycemics, meaning that these medications lower blood sugar to help treat hyperglycemia. Oral hypoglycemics can only be utilized for the treatment of diabetes mellitus type 2, as they require a functional pancreas and insulin production. Glipizide and repaglidine are oral antidiabetics that work on the pancreas to stimulate the release of insulin. They should be taken before meals to facilitate enough insulin secretion to allow for the glucose in the meal to be adequately taken into the cells. Dosing should therefore coincide with meals and should be skipped if meals are skipped, or added if a meal is added, for up to 4 meals per day. Since glucose is drawn into the cells and out of the serum, a side effect of these medications is hypoglycemia. Patient education should focus on teaching patients the proper timing for administration and for recognizing indications of hypoglycemia, such as confusion, tachycardia, diaphoresis, and lightheadedness. Metformin is another oral antidiabetic, this one working on the liver to decrease the release of glucose from the organ, as well as increase insulin sensitivity and uptake of glucose by the cells. Since the liver is active upon, the functionality of the liver becomes one of our primary concerns for patients using this medication. Severe liver damage can occur due to lactic acidosis. This risk is correlated with the use of IV contrast used in CT scans. So it is imperative that this drug is held prior to the scan and held for a minimum of 48 hours after the scan is completed. Also of note, this medication is known to cause GI distress and severe nausea and diarrhea for patients. These GI impacts may be lessened if metformin is given with meals, as well as supplemented with adequate vitamin B12 and folic acid. The upside to this medication, however, is that there is overall a decreased risk for hypoglycemia, as insulin production is not directly acted upon, but rather insulin sensitivity. The final oral hypoglycemic in this section is acarbose, whose name tells you what it's all about. Acarbose inhibits the breakdown of glucose, and the substance remains undigested. It should be taken immediately prior to meals in order to act upon the food ingested. By making glucose not bioavailable, this of course means that hypoglycemia can occur over time if not enough glucose is kept in the serum. Long-term use is correlated with liver damage, anemia, and GI upset. This medication is indicated for those who do not have a functional pancreas or liver, as it does not recruit either organ to have its desired effect. However, acarbose is generally not effective as a monotherapy in the treatment of diabetes. This next segment focuses on injectable hypoglycemics, those drugs which also act to lower blood sugar to treat hyperglycemia. These may be used in patients with type 2 diabetes and are required for use in patients with type 1. All of our insulins act to lower blood sugar by serving the same function as endogenously produced insulin, facilitating the uptake of glucose into the cells. With all of these medications, our main concern is of course hypoglycemia, with risk increased if improper dosing or failure to consume enough food at peak effect occurs. Patient education should emphasize monitoring for indications of hypoglycemia, which we have already discussed previously in this video. Insulins can be rapid-acting, regular, intermediate, or long-acting. Depending on which of these categories they fall into, there are different onset of action, peak action, and duration. Our rapid-acting insulin, such as Lispro and Aspart, may take effect within 15 minutes of injection, reaching their peak around 60 to 90 minutes. Therefore, with these rapid-acting meds, make sure the patient consumes their meal within the interval of time before onset of action is expected, or else hypoglycemia may occur. Regular insulin is special, as it is the only kind indicated for IV use. This is due to its quick effects if given IV, but not as quick and intense as if rapid-acting insulin were to be given. Onset if given sub-Q is around 1 hour, with peak anywhere from 1 to 5 hours after administration. Intermediate, such as NPH, has a distinct cloudy appearance due to the presence of proteins in the solution. The vial should be rolled between the hands to mix a suspension, and when combining insulins in the same syringe, make sure the solution is drawn up after the clear insulin is drawn up first. Finally, our long-acting insulins. Of note with these medications is that they do not have an outstanding peak, rather providing more continuous and gradual effects over a 24-hour period. Do not combine long-acting insulins with other insulins in the same syringe. Let's review some more principles related to safe insulin administration. Verify insulin units with another RN, as these are high-risk medications. It is a priority to monitor the patient for indications indications of hypoglycemia when the peak effects of the insulin are projected to occur. Doses may need to be increased when there is greater demand for glucose utilization, such as during periods of stress, illness, and exercise. Insulin is usually given via SQ injection, with administration into the abdomen being the site of quickest absorption. As mentioned before, if needed to be given IV, only regular insulin is indicated. Insulin pumps are another option, with continuous infusions based on basal metabolic rate requirements and bolus doses of rapid-acting insulin administered as needed for these patients. A final note about insulin. A side effect of use is that potassium is also drawn into the cells, leading to decreased serum potassium levels. Especially if given IV, the patient should be monitored for indications of hypokalemia, such as weakness and U waves on their ECG. Potassium replacement may be indicated if the patient is receiving IV insulin therapy, such as in the treatment of DKA or HHS. By contrast, these hyperglycemic medications create a spike in blood sugar in order to treat hypoglycemia. Glucagon is an injectable medication which stimulates glycogenolysis in the liver to increase serum concentrations of glucose. Patient education should emphasize that patients keep a pre-filled and safely stored glucagon syringe on their person at all times. In the event of severe hypoglycemia, where PO intake of carbohydrates becomes impossible or ineffective. Adverse effects include severe GI distress and emesis. Unresponsive patients given glucagon should be turned on their side to prevent the aspiration of emesis. Fun fact: this medication may be given off-label with nitroglycerin for the treatment of food bolus obstruction. If IV access is available, IV dextrose may be indicated to restore adequate serum glucose levels for severely hypoglycemic patients. Additionally, this medication may be used in the treatment of diabetic ketoacidosis in order to prevent cerebral edema and rebound hypoglycemia from occurring. Since the IV solution contains dextrose particulate, there's a high risk for phlebitis, and so administration should be in a large vein and slowly pushed. Monitor for patency of the vein throughout the duration of the therapy. We will now discuss medications that may be seen in the treatment of hypothyroidism and hyperthyroidism, respectively. First is a medication used in the treatment of hypothyroidism, that being levothyroxine. This medication is a synthetic free T4 replacement. Patient education should emphasize adverse effects and proper administration. Levothyroxine should be taken first thing in the morning and on an empty stomach. The drug should be taken daily as indicated, and sudden discontinuation can lead to severe rebound hypothyroidism, known as myxedema coma. Side effects of levothyroxine mirror findings present with hyperthyroidism, such as tachycardia, anxiety, tremors, and diarrhea. Doses should be titrated to demonstrate symptom improvement from the patient's hypothyroidism, whilst likewise limiting the effects of too much circulating thyroid hormones. Now onto treatments for hyperthyroidism, first starting with propylthiouracil, or PTU. PTU is indicated for conditions such as Graves' disease. It acts to block the conversion of T3 into T4. Side effects of this medication mirror those associated with hypothyroidism, such as depression, lethargy, weight gain, and hypotension. A more intense treatment is iodine-131, often seen in the treatment of thyroid cancer and prior to thyroidectomies. This medication is radioactive iodine and absorbed by the thyroid gland, leading to its inactivation and destruction. Since the gland is being destroyed, after this medication is utilized and a thyroidectomy is performed, patients will then need to be on lifelong levothyroxine in order to achieve normal physiological levels of thyroid hormones. Being a radioactive isotope, this medication must be handled with appropriate guidelines. Users may have to self-isolate and utilize designated equipment, linens, and areas for waste disposal during the duration of this therapy. Adverse effects include bone marrow suppression, radiation poisoning, and of course, expected hypothyroidism as the gland is destroyed. Disorders of the hypothalamic region and associated hormones released from that region often require pharmacological interventions. Somatropin is used for the treatment of conditions of growth suppression, such as with wasting syndrome and Turner syndrome, to name a few. Growth is stimulated in bone and muscle, as this medication takes effect on the anterior pituitary. These medications should be discontinued once maximum growth is achieved if used in growing pediatric patients, so routine x-rays are indicated to monitor for the closure of the epiphyseal plate. Complications of therapy include hyperglycemia, hypercalcemia, and increased risk for renal calculi, as well as myopathies. The medication is contraindicated for use in diseases that impact hormonal regulation in the body, such as diabetes and disorders of the thyroid, for example. Acting on the posterior pituitary is the medication desmopressin, which is indicated in the treatment of diabetes insipidus. The therapeutic action of this medication is to decrease urine output and to facilitate the retention of free water in the body. This is achieved through vasoconstriction, which allows for greater resorption of free water and for urine to become more concentrated. Side effects include fluid retention and relative hyponatremia. The patient should be monitored for indications of water toxicity, such as acute confusion, increased intracranial pressure, and seizures. Since vasoconstriction is occurring, be sure to monitor for hypertension and ischemia. While often given intranasally, if given IV, make sure to monitor closely for extravasation. The adrenal system, which can act to mobilize our sympathetic nervous system responses, may also require pharmacological interventions if abnormalities are present. Hydrocortisone and fludrocortisone are medications that can be used in adrenal insufficiency, also known as Addison's disease. In this disease, not enough cortisol is produced, and thus the sympathetic nervous system is not adequately employed during periods of stress, illness, or injury. Exogenous steroids thus stimulate production and release of cortisol. With adrenal insufficiency, these treatments are lifelong. The smallest effective dose should be used, since adverse effects and complications can emerge as a consequence of these medications. Noted complications include hyperglycemia, fluid retention and weight gain, hypokalemia, and hypernatremia. Doses should be increased during times of stress and illness, and in the event of any surgeries or injuries, in order to facilitate meeting the body's demand for the activation of the stress response. Thank you for watching this quick review of endocrine drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.